So it's a pleasure to introduce Dr. Vaanathi Sundaresan to you. She is a freshly minted professor at IISER Bangalore, who came there via IIT Madras and the University of Oxford. She works in medical imaging and the use of machine learning in medical imaging. She's the Department of Computational and Data Science at the IISER. And she'll speak about artificial intelligence in medical imaging for precision medicine. Go ahead, Vaanathi.
Thanks, Professor Gautam, for the wonderful introduction. And good morning, everybody. So yeah, as Professor Gautam said, I'm Vaanathi, and I'm an assistant professor at CDS department, also the convener of Biomedical Image Analysis Laboratory. So today I'm going to talk about AI in medical imaging for precision medicine. Right, so before I dive into the topic, I would like to give a brief overview of how this talk is going to be organized. So first, I would introduce the importance of medical imaging in precision medicine, and later I will move on to AI applications in imaging for precision medicine, focusing on few of my work in the AI applications at individual subject level for precision medicine and also for population level analysis of different diseases and their progression. And then we will see the major challenges in AI tool development in clinical settings. So the main things that I'm going to discuss is data and label limitations, mainly from medical imaging perspective, and domain shifts across different centers and domains, for example, from different scanners and different hospitals, and also the data sharing and privacy. So the third thing is especially important because medical data is very sensitive in nature. And moving on, finally, I would finish up with the opportunities and future directions currently available, the major things I could think of in precision medicine. So what is precision medicine? So precision medicine aims to provide personalized care for subjects based on their lifestyle factors. For example, whether the person is smoking or not, and whether they are obese or what are their dietary activities or habits, and also the subject's medical history. So do they have a history of hypertension, diabetes, and how can we treat them based on these given their medical history, and also disease biomarkers. So given so if they have taken routine scans, so what can we say about various lesions or various structural abnormalities that we find in their scans? And finally, genetic factors, if we have access to them, the genome information, or to some extent from their family history as well. So let me give a small example. A patient walks into a clinic and says that they have mood changes and starting to develop gait disturbances. So when they are walking or when they are doing some activity, some motor-based gait disturbances. So what would the initial thing would be that this can be a symptom for anything, right? There are so many reasons why a subject can develop mood swings. So, but then if I give you some additional information about the subject, like, so they have hypertension and or history of diabetes. And if we take a MRI scan, it reveals lesions or some abnormalities in certain regions of brain. And also we know that that person has a habit of smoking and is prone to stress due to work activities. Now we know that probably they are developing early stages of neurodegeneration, or they are having a very severe case of small vessel disease signs. So these could be a very useful and crucial biomarkers that could help us in the right direction for precision medicine. So we know exactly how to treat them. So now I'm going to go ahead and give you a few applications or use cases for medical imaging in precision medicine, how exactly medical imaging can be useful. So first is early diagnosis, where you have routine scans throughout your life, right? Every 6 months, every 1 year. So we can find, this could be an important opportunity to find any incidental findings. So what does incidental finding really mean is that, so you are not expected to find any targeted abnormalities, but something lights up in your scan, right? Some kind of abnormality. So the earlier we find, the better, the timely treatment can be provided. And the next one is differential diagnosis. This is what I was explaining to you earlier, right? So you have same set of symptoms for different diseases. So how do we know, how can we discriminate what exactly the cause of the disease and how can we treat them? So when we look at the imaging modalities, the scans, possibly the location of lesions or the way they progress along the timeline. So that could give us useful biomarkers about how the disease is progressing, what kind of disease the subject is having. Finally, screening and treatment planning. So this is more along the longitudinal studies where you have scans at different time points to see how the disease progresses and also how it reacts to a certain treatment. For example, if you are administering a specific drug to the subject or a patient, so how well the lesion load is reducing. So is it remitting in any other part of the, let's say, for example, some neurodegeneration, is it coming back in some parts of the brain or is it going away for good? So we can know these things and we can also plan our course of treatment accordingly. And monitoring and predictive analysis. So this is to predict the severity of the disease over specific time points. And also if surgery is involved, what is the condition of this particular lesion or the disease biomarker before and after surgery? Has it gone away completely? And what is the reduction in volume? So is there any chance of it coming back? So this is quite common and also the most important thing probably that is tangible in AI applications, right? So data-driven and hybrid decision making, where we use data and features to train the models so that the model can help in decision making. At times, if we know more about the domain, we can include domain knowledge as well, as in like what kind of lesion we are looking at and how much is the quantitative load of lesion that has to contribute this particular decision or screening of the disease. So it can be a combination of both data-driven and rule-based. So the later I explained was what we call as rule-based, based on certain parameters like what is the like lesion load or what. So you can divide the images into different zones, and based on where the lesion is, you can say that it's severe or mild or moderate. So gradations you can give. So this basically is the combination of both. And finally, apart from clinical applications, so we have research application too. So further understanding of disease conditions. So for the researchers, clinical researchers, to get an idea of different kinds of diseases that can develop from a same biomarker, and how can we track the progress of them, and what can we understand more about the disease progression and manifestation. So for that, we would actually need more of a population level modeling, because we can't just go with how the signs happen at individual level. We need to have a more wider, for want of better word, I would say prior. We need a better prior, wider prior, or more generic prior for us to understand how the disease is working in large scale. So, so far I have worked in a few AI applications in imaging for precision medicine. So first is early diagnosis. So this is especially one of the most important and challenging aspect, this detection of microbleeds. So microbleeds could be possibly the earliest sign, small vessel disease sign for most of the neurodegenerative and cerebrovascular diseases. And it's doubly hard to detect because they are extremely small. So I have zoomed in and showed. So basically this is how we localize it. Extremely hard to detect. And if we can detect and quantify them and diagnose at early stage, the disease is reversible. And the second thing is screening and monitoring, where I was working on retinal imaging, screening the severity of diabetic retinopathy and age-related macular degeneration. So we were working on end-to-end pipeline, where we have detected different signs related to the early stage, intermediate stage, and the later stage as well. So the later you go, the signs are more obvious, right? It's very hard to detect usually the early signs, and it's very useful to detect them too. And finally, extraction of imaging biomarkers. So when I say biomarkers, they could be pathological signs or any quantitative measures you can receive or you can observe from the structural abnormality of brain. So we call that as anomaly detection, where we see any kind of anomaly a deviation from normal structure in the brain anatomy that's not supposed to be there. So I was working on white matter lesions. So the interesting thing about white matter lesion is that they can occur in healthy elderly as well. At the same time, they are cause for pathological like neurodegeneration or even cerebrovascular diseases. So how can we differentiate healthy aging from pathological aging? So the first step is to identify these things, these lesions, and then to quantify them further for clinical analysis. And then the brain tumor lesions as well. So these identifying these lesions, as I said, is the first step towards quantifying them and then using them for either clinical prediction or for research analysis. So, and then demographic factors. Right. So moving on, the next aspect is the demographic factors driven population level modeling. So where we can, in addition to working on subject level, so what can we understand more at population level? So for instance, I have shown here the common demographic clinical factor, right? So blood pressure. So once we have these lesion maps corresponding at subject level, so let's say that there are 50 subjects who have reported to that hospital with blood pressure, and we find lesions in different regions of their brain. So from these, can we construct a population level lesion distribution map or an abnormality distribution map? So, and can we relate these location to how these factors these are the risk factors. So how can we say that this location of these lesions will correspond to this? So in other words, can we say if the 51st patient walks up with hypertension, we need to know where to look in the brain for these lesions. Can we get that information from this map? And not just one biomarker. For example, there could be ischemic lesions and also hemorrhagic lesions. There are different types of lesion biomarkers. So what can we say about the co-occurrence or the joint map of these lesions? So we can say that these pathologies are co-occurring for this type of risk factor. Age could be one, blood pressure could be one, presence of diabetes. So what can we say about the interactive effect of these lesions? So one such work we did was modeling these white matter lesion distribution at population level. So we chose UK Biobank data, which is the largest imaging database, brain imaging database. So they currently have around 40,000 subjects scanned with the aim of scanning 100,000 subjects soon. So what we did is that we detected the lesions, white matter lesions at subject level. And then we took two factors. One is age and another is hypertension, what we call as blood pressure in day-to-day terms. So now I have shown the difference between the lesion distribution at two levels of hypertension. So one is the patient is hypertensive, the other is the patient is not hypertensive. And for the two age groups as well. So 60 to 65 years, which is slightly younger group, what we would expect for these kind of diseases, and also the elderly group from 77 to 78. So if you observe carefully, so the lesion load between age is increasing for these regions around ventricles. However, the only difference that happen between hypertension and non-hypertension is the regions in the deeper regions of the brain. These lesions increase in the deeper regions. So giving us an idea of what areas to look at if a subject is walking in with hypertension. So we also confirmed this with the significance map, which showed the higher level of significance in these deep areas for hypertensive subjects for white matter lesions. So those could be some of the AI applications, some examples actually of AI applications that could be used in precision medicine. So moving on to challenges in AI tool development. So when we develop a tool, for example, like a deep learning method, it's going to need a lot of data, some examples from which we can train the model. So however, in medical imaging, so we have to basically get the data from clinics. First of all, even whatever, it's very difficult to get medical imaging data, not as easy as you think. And the data has to be anonymized because we don't want any identifiable patient information. On top of it, So clinical doctors and radiographers, they are very busy people. So we can't ask them to sit down and do some manual labeling because we need those for training the model. We need data with abnormality, let's say, and we need to know where the abnormality is for training the model, right? The model has to learn from somewhere. So it is it's a big ask to ask from clinicians to sit down and mark those regions because they're extremely busy people. So what can we do to overcome these limitations, overcome the need for manually labeled data? So for instance, I have shown here the three modalities. One is brain imaging for tumor segmentation. The another is retinal imaging for macular degeneration segmentation. The third is cardiac MR imaging. And so usually the cardiac valve is like the left ventricles. The ventricular wall is supposed to look thin, but this is an anomaly case where it's actually swollen up. Right, so we want clinicians to ideally help us with these. But what can we do to reduce their effort as well? So the first thing is use a semi or self-supervised method. So taking a step back, let me explain very quickly what supervision means. So this process of model learning from manual input. So we will give input and we will give targets, what we call as ground truth for the model to learn. So this process of the model training is called supervised learning or training. This training can be supervised where we give the manual targets for the model to learn, or it can be unsupervised where the model learns from the intrinsic data properties. So what we can do is make the training process semi-supervised, where we give a very less number of manually labeled data. So we are giving some data for the model to learn, but the model mainly uses unlabeled data. And also self-supervised method, where the aspects of abnormalities are learned from the data itself. So we can use these sort of methods to overcome this limitation of requiring manual labels from the clinicians. Another thing that we can do is ask for weak labels. So not exactly mark, for example, here the whole region is an abnormality. But if the clinician marks just part of the lesion, the model should be able to learn the whole lesion, so the whole extent of the lesion. So these are some of the techniques that can be used to reduce the clinician load of radiographers. At the same time, we can actually create a very robust model that can work across different domains. So one of my students recently has been working on ANOSynth, which is a self-supervised multi-scale anomaly detection method on medical images. So what happens is that, so the main advantage of this method is it uses completely healthy controls. Normal data doesn't require any examples of anomalies to be fed in, so that is internally generated by the model. And also it's extremely flexible because we are generating anomalies or examples for the model to learn at multiple scales. So we can choose what scale the model need to learn, very small lesions or very big lesions, that is entirely possible. So first step is the simulation of these lesions. So multiple scales of anomalies. We take a normal noise. So it can be a Gaussian white noise, and then we take it in different frequencies. So that determines how much spread, what is the size of lesion we are aiming for, and also the smoothing factor, which would give us the extent of the lesions. So we interpolate these anomalies on the original input healthy image. So now the image looks like it has got anomalies when we interpolate or add these regions to it. So once this happens, these examples can be given as training examples for the model. So we are not using real lesions, but we are simulating the real looking lesions. So we were using, so how many of you here are familiar with transformers, vision transformers, or any kind of diffusion models really? Right. So just to give you a brief overview, so what happens in the transformers is that if you have an image, so especially in vision transformers, so if you have an image, so these images are taken as patches, small patches, and these patches are taken in a linear order, vectorized, and there is basically a transformer encoder that happens, which gets in both the patch-based information and also the location-based information. So for example, if this is the location, both the information goes in the patch and both location level information goes in. So this usually the vision transformers have most of like the location context and also what kind of anomaly to detect. And then it basically goes through a series of steps. So what you need to understand is that it gives a more robust segmentation result or detection result, which gives a better feature quality than the normal methods, segmentation models. So what we use here is a unit which is a U-shaped architecture where this vision transformer is used as an encoder, and we use decoder features basically to get both the context and texture information of these anomalies. So that's what we use for training. And so these are some of the results we have got. So for example, here we have shown the two sample images from brain tumor segmentation data sets. So our method was able to get the tumor regions of multiple scales, different scales and different textures. So identifying these large lesions is straightforward, but getting these intermediate and small sized lesion requires a lot of training. And we also applied our method on another data set, a retinal imaging data set called STARE. So here we were looking at both, these are like intermediate signs, and this is a very late stage sign of diabetic retinopathy. There is actually the macula has completely degenerated here. So our method was able to get these signs and also some of the mild drusen or the intermediate signs that were occurring along with them as well. And so we were able to get a better result from the existing state-of-the-art methods for both localization and image level results. So another work that we have been working on is a weakly supervised method where we had given only image level labels. So looking at the image, we know whether that image has stroke lesions. So here we are working on stroke hemorrhage lesions. So here we know whether the particular slice has stroke lesions or not. So from there, how can we say exactly where they are located and also what is their size and load? So for that, we actually took the input CT slice. So CT has very poor SNR compared to MR. So most of the imaging techniques use MR for clear-cut decision, but then CT is quicker. So emergency medicine, usually they use CT for observing stroke lesions. So here, that's why we took a CT lesion, and we wanted to localize the region of intracranial hemorrhages. So here, based on the classification model, we get class activation maps. So what are class activation maps? So when a model makes a decision, we want to know what are the salient regions in the model that has important features that are contributing to the decision. For example, there is this whole image, and that's the white region is the skull, the border kind of thing you see, that's the skull. So the skull definitely is not going to contribute to anything because all of us have skull, right? So what is the anomaly that is contributing to the decision of whether there is stroke or not? So those areas will light up in class activation maps. So we use these maps to further refine the boundaries, and then we get the output binary mask. So that is what we do based on the classification result itself. What can we do to improve the segmentation or the localization result? So testing phase, it's even better because this whole cumbersome process happens only in training. In the end testing, so this is the main model that we want to train, because this whole process is to create these pseudo labels for this model to train, essentially finding out where the lesion is and then using that for training this model to get the final output. So essentially while testing, all we need is the final model. So it's extremely flexible and also less time consuming. So it is very useful, especially in clinical applications, to think of methods that would be less time consuming, which would require less data and also would be robust across different domains. That is what clinicians want, right? So they don't want something that they have to retrain every single time. So again, a few results we had. So, so this is where actually, so you can't see anything from here. So we did some pre-processing, converting the color space, and then there is some lesion here and a small lesion. I don't know if you are able to see it here. So our aim is to get the location first, which we were able to get from the CAM maps, and then refine it further, and that's our segmentation output. So we also did a additional experiment where we wanted to know how the CAM map can be improved or the class activation map can be improved. So here we initially found that this is our the location without having dependencies across different slices. So we get a 3D volume. Either MR or CT, we get a 3D volume of your whole brain. So we want to know which slice has it, and having that spatial continuity across slices is really helpful. So just using that spatial continuity, we were able to get a better, with better localization and better specificity and precise CAM map. So we were able to get better results for intracranial hemorrhage detection. Now, do you have any questions before I move on to the next topic? Yeah. Yeah. This one? Yeah. Yeah, that's a very good question. So we have something what we call as continual learning or active learning. So where the clinician would mark actively what are the, so usually doesn't happen with stroke or hemorrhages because they are quite big and the patient has already been admitted. At this point, with this kind of lesion, they would have got admitted into emergency ward, right? So that's where we want to find out. So for early signs like lesions that I was talking before, there is chance of them recurring. So the doctors would be adding more areas, let's say, in on longitudinal images or in different time points. So we have something called active learning, where it takes into consideration what is already there and what has to be added to the lesion segmentation or any kind of model, any learning process. Let's generalize it. So what can be done to the weights? How can you update weights? So one thing is a very basic fine tuning with transfer learning, if you are familiar with the term. Yeah, so if not, then we can actually add in the feature latent space, we can keep adding more features, which are more generic. So you have this feature manifold in the latent space. So you add specific aspects of feature that can be tweaked so that it loses its specificity in space. It can be anywhere. So more domain generic or location generic features will be added. So that is one, this is, there are many ways to do it. I'm just saying one way of doing it in real time. Did that answer your question? Yeah. Any other questions? Yeah. Yeah, great. So, so for those whom you don't know, basically MRI has 3 views, right? 3 dimensions means 3 views. So he's referring to the 3 dimensions, 3 views of it. So axial, coronal, and sagittal is what we say. So as he said, the different structures light up in different, you see different structures in different views. So how we choose the first thumb rule in data analysis for any data analysis, not even medical data, is basically you have to read your data. You need to know what kind of data you have, what aspects you are learning from the data. So if you have a particular task in mind, for example, any kind of lesion detection, you have to see in which plane the lesion shows up. Sometimes your data might be a 2.5D acquisition, right? So one of the dimensions will not have higher resolution. So definitely the best thing to do is to avoid that resolution. So if you have a higher resolution across axial, so I would suggest you take your axial slices to go with it. So another aspect you can follow is that try the method in all 3 dimensions and take the one that works best. So we recently developed a triplanar method that actually does that. It combines the prediction from all 3 dimensions. So regarding the number of slices, it again depends on how much nuance you need in your precision or need in your prediction. So if you want your prediction to be better, you need to have a representative set of data. So what constitutes that representative set? Can 10 slices inject that amount of variability in the training data? So you need to have enough variability in the training data for the model to learn different sets. So it depends completely on your data, the resolution or the noise ratio of your data. So we usually take for most of the applications the axial slice, because that is where this is an axial slice, right? So that's where the abnormalities show up. And also we take, for a normal training like this, we take 100 to 200 number of slices. But again, it depends on the complexity of model and the variation generally found in the disease signs and the variability you find across different centers. So you need to decide accordingly the number. Right, so let's move on to the next important challenge, which is data domain shifts in multicentric data. So to put it more clearly, let's say you are getting data from 2 hospitals. They use 2 different scanners. So one, let's say, uses a GE scanner, MR scanner, and another uses Siemens scanner. And they all use different imaging protocols. So they will have, the radiographers will have set of protocols or parameters to acquire the model image. So that set of parameters will remain very different across different scanners. And it might actually be different even within a scanner, depending on if I am scanning or if someone else is scanning. I will set different protocol parameters depending on what contrast I need in the image. Some other person might not choose it. They might want a better SNR, so they might choose a different set of parameters. So the images that come out of this, even for the same subject, is going to be extremely different. Even a small difference can break a deep learning model. So now how are we going to make a model which is going to work robustly with the same performance, right, with the same accuracy across different centers or different scanners? So that is what we call as domain adaptation. So you will find this terminologies in many of the ML applications. It's not very specific to medical imaging. Any ML based application. So with people who have done hands-on work on ML model development, any model, even conventional ML model, you would know that you develop, you train the model on a data set. You apply on test data set. Does it perform as well as training data? And you move on to a completely new unseen data. The performance decreases, right? So that is what we call as domain related shift in the data sets. So how can we overcome them? Here I have shown a few different MR images. So all of them are brain images. All of them are from the same age group. Now the variation comes, as you can see, they are not similar. The model that is trained for these couple of things is not going to work definitely on this last image. It's extremely dull, right? The contrast is very poor. So how can we make the model work? It can be due to difference in scanners, due to difference in the patient's demographic group or the patient's pathological thing. Healthy controls brain will look very different from a pathological brain. And also here I have shown another phenomenon where, okay, in case if we take all of these models put together and train it, there is going to be a new set of data, which is going to be completely different from what you have trained. And how can your model adapt to it in test time? This is what we call as test time domain adaptation. Very dynamic, it has to go on the fly. You can't train it again. So how can your already trained model work on a new set of different data? So here we did comparison of various domain adaptation techniques. So we took white matter lesion segmentation as our main task. So our aim is to detect white matter lesions. So how can this task be adapted to two different domains? Let's say the first is source domain, and we usually call the one that it has to get adapted to as target domain. So initially we just took the model that was trained on source domain and applied on this. Why did we do this? To get a baseline. So we need to know what is the intrinsic capacity of the model. If I take the one that is trained on baseline, apply it directly on target, that will be my baseline. That is the absolute worst that model can do, right? And then we developed a few more techniques. We compared a few more techniques. The first one is pure transfer learning, nothing special. So we just took the model here from here, and then we froze a few layers and fine-tuned the last few layers and applied it on the target domain. And the third method is what we call as domain adversarial training. So in deep learning, we have backpropagation, right? So what happens in domain adversarial training? So we have a feature extractor. This is again a DL architecture. This extracts features. And then we have two arms. One is label predictor arm. So label predictor will be the lesion, it predicts the white matter lesions or whatever task you are focusing on. The another one is domain predictor. Right, so this predicts which domain or which scanner the data is coming from. Now, we want the model to perform better here. We want the model to perform better, and we want the model to perform worst here. In other words, the model should become so bad in recognizing the domain. Right, so the model should be progressively trained for label prediction and adversarially trained for domain prediction. So for that, we introduce a negative lambda factor. So this is what we call as gradient inversion, reverse gradient reversal. So when in backpropagation, when the gradient is estimated, when this gets consecutively better, when the model finds its local minima during convergence, right, this task would get better. Because there is a negative gradient flowing through this arm, this task would get worse. So this is what we call as adversarial training. So we did both in unsupervised and semi-supervised manner. So we would need, if you think about it, we would need labels both for lesions. So basically where the lesions are in the brain. That is this label. And we also need domain labels. For example, I will put one for all GE scanners and two for all Siemens scanners. So we need two types of labels for this. In unsupervised method, I will take labels only for domain. I know where the data is coming from. I don't know where the lesions are for the second domain. We are completely avoiding that. We don't want the radiologist to provide anything for this. This is reducing their time. In semi-supervised, the second type, we ask for some proportion of labels. Let's say if they are giving 100 images, we will ask for 20 images with labels. So for the remaining data, we need only domain labels. So this is a very efficient architecture for domain adaptation. And the last one, the 5 where I have shown unsupervised domain adaptation. So that is the in-house method we developed. So in DAN, the 4th method, so the both label prediction and domain prediction happen simultaneously. But in our method, we do it sequentially. First, the feature extractor gets trained, and then the label predictor, and then the domain predictor. So the domain invariant features are included in the next cycle of label prediction. That's why we do it sequentially. So we compared all these methods, and we found that still the domain adversarial training, which is 3 and 4, performs better. In 3, it's even better because between 3 and 4, we didn't find any negligible difference. So there is no use putting some label data, right? So we actually found that we can as well use unsupervised data. And we again applied this method, the third method, on the 2 more applications, which is multicentric cardiac image development. So the multicentric cardiac image segmentation And also for classification of chest X-rays, normal and abnormal X-rays, it worked well. Basically, we got this data from, I'm not wrong, I think 6 centers. So it worked well on most of the centers when we applied this method. And the third most important aspect is data sharing and privacy protection. So as I said, medical imaging data is extremely sensitive, right? So if your scans are taken, you wouldn't agree to be shared, the scans to be shared. So that's a very common concern. Even for getting data, we need to get a written ethical consent from the participants, and even for getting any study data. So what could be the way to circumvent this? Can we do it without sharing the data, without asking for this? Right. So one such thing is federated learning. Some of you might have heard about it. So it's not even, it's not a popular term just in medical imaging domain, but also in most of the sensitive data like financial data or defense data. So they also use federated learning framework. So what it does is that, so the data is present in individual centers, right? Individual hospitals or centers. And then the model is present in the centralized server. So instead of taking the data, what would we do? We would take the data and then we would train the model, right? So instead of doing that, what if the model parameters can be shared with the data premises without the need for data to leave the premises? We will share the model parameters. Now it's distributed. The learning happens in the individual centers independently. Now, how can I develop one model? So what I do is I aggregate these model parameters that are trained in individual centers. I aggregate it and I send it back to the centralized server. Now, there are problems with this aspect, this framework as well. There is an aspect of synchronization where how often this aggregation happens and sends back. And also what happens if a new center is added, right? How would it impact this aggregation process? So these are some of the concerns with federated learning, but it's actually gaining immense popularity, and the growth rate of papers working on this the groups working on federated learning has increased immensely because it provides an answer to the privacy problem that we encounter with medical imaging data. So as I said, some of the emerging areas of research in federated learning is addition of unseen centers, right? So you train it with 4 centers. What if there is a 5th center with completely skewed data, right? So those are the things that we have to work on. And also cross-modal domain adaptation. Let's say that I told you that CT is taken in emergency medicine, medical cases. So what if there is a hospital which has a different protocol? They only take MR, they don't take CT. Even if there is an emergency, they take MR. Maybe they want to earn more, or they want to actually see, because MR has better specificity than CT. So they want to see where exactly the lesions are better. So they take only MR, but your model is CT because you know that CT is the common thing for emergency. So you have developed your model on CT. So how can your model be adapted to across modalities from CT to MR? So that's cross-modal domain adaptation. And missing modalities. So what if some of the modalities are missing in the imaging protocols? They don't acquire, instead of 3 modalities, they just acquire 2. How can your model that is working on 3 modalities be adapted to this new center that is coming up with only 2 modalities? Right. So let's move on to the final thing, which is opportunities and future directions. So the first is actually a very, very important and rapidly developing area in medical imaging, which is interpretability and trust. So your model is just churning out some results. Radiologist who doesn't have much technical knowledge, how can they trust your model is doing good? I'm saying 94% accuracy, 95% accuracy, that's all numbers to them, right? In a sense, they don't really understand what is going on, because deep learning models, for their efficiency, they are black boxes. But that situation is changing right now. So what can we do to make our results or the working of model more explainable so that the clinicians can participate in this whole pipeline? So what if there is more explainability, the clinicians can provide their feedback, right? That can be inputted in the model integrated into the model. The models can be made better. So we call this as bidirectional interaction between clinicians and AI models. So how can we ensure that? So there has been some research. There are still a lot of scope for this research. And the first thing is feature saliency. So can we actually, from whatever the model has learned, can the model provide a saliency map which can show what are the important regions in the brain it is looking at while taking the decision? If a model says that this patient has stroke, what are the regions it looks at in the brain to arrive at that decision? So maybe the clinicians can say, no, look at this region as well, right? So that is one aspect. And another is output class probabilities. So if a model is saying that I believe this is a lesion, instead of giving a black and white, a binary 1 or 0, what if it gives a more percentage or like more gradation of results? I think that this is 25% background and 35% ventricle lining or other tissue, and only this much, like 40%. This is basically how much certain I am that this is a lesion Watson. And then example-based explanations. This can be incredibly useful in training new radiologists. If a radiologist comes in, or radiographers, they come in, they want to see more instances of how this abnormality would look like. The model has already learned so many examples of how it would be looking like. So from that, can it be a generative model? Can it generate more examples of this artificially, but then more realistic looking instances? So the radiographers would learn, these are the instances, this is how a new instance is supposed to look like. So these could be a few aspects that can be experimented in interpretability and trust. So another aspect of interpretability is uncertainty. So if your model is giving results, how certain it is in the different regions of the pathology itself. Usually the model is very certain in the middle part. Only along the boundaries, it doesn't know where exactly to place that boundary because it's blurred out, right? In most of the modalities, it's blurred out. And the lower the resolution is, the blurring is going to be more. So what can we say about the uncertainty? Because this size is going to contribute to the lesion load. The smaller it is, we are going to misunderstand that the lesion is getting smaller, right? So the model has to be very clear about where it's going to place its boundary. So what kind of measure can we estimate to know its certainty along boundaries? So the next thing is out of distribution detection. So far, I was telling you that, okay, we are detecting stroke, we are detecting lesions. So I know what I'm going to detect, but that is not the case in real world scenario. There can be any kind of abnormality. So how can we make what we call as targeted disease detection as an open world problem? So it's more of an open world where we don't know what exactly is going to coexist or what kind of comorbidities are going to exist. And one way to go about it is basically find any kind of structural abnormalities present in the image and then group them into baskets. These are probably the bright abnormalities due to ischemia. These are like dark abnormalities due to blood leakage or hemorrhage. And these are due to scanner related abnormalities. If the patient has moved, there is jittering artifact in the image. So because of that possibly. So it would be good to actually get a open world anomaly detection problem. And then even more importantly, to integrate it with this federated learning framework. Just think about it, right? If we have this kind of framework integrated into a distributed learning framework, it could be a veritable mine of resources. It could be a mine of getting all these new type of pathologies from new centers. So that could be very useful in clinical setting and for research perspective as well. And so this can be used as again prior, as I said, in more population level, going back to my previous slide, just connecting back. It can be used for precision diagnosis, knowing where the location-based prior are. And the last one is basically extraction of underexplored biomarkers. So we have only scratched the surface of what could be the possible reason or the possible signs for specific type of diseases. More and more being explored by the clinical researchers over recent years. So working on those signs as well. And this is something that actually requires some expertise from NLP, natural language processing as well. So how can you report automatically what is being generated? So one thing is to get the boundaries. The other thing is to qualitatively describe the lesion that you have detected, right? So can you do that? How can you do that? And what would be the applications of such reporting? With this, I conclude my talk. And thank you so much for your attention. And I would like to thank my group at CDS Biomedia Laboratory and my collaborators at Oxford and elsewhere. Thank you very much. So that's a very interesting question. So it again depends on application, right? So for now, so far, UK Biobank is the largest database we know for multi-organ study, which means they have multiple modalities for the same patient. When the patient walks in, they image for all the modalities. X-ray also they take in addition. But we don't get this clean multi-modality data from most of the studies, right? This actually involves a lot of things. They have to go through MR scanner, they have to go through retinal imaging and cardiac MR as well. So usually what we do as a crude way of matching this, we take a approximate match, like we age match, we take with the, basically if you want to take a population, what we call as a population, with the same demographic factors. Like for example, Caucasian population or Indian population, we try to take with the same similar age group, with similar sex ratio, and with similar dietary practices, and with similar lifestyle factors, so that we are matching, right? We are trying to get the characteristics for that particular population, if not for the same patient. We do the next best thing. If not, if we don't have data which has multi-organ study, we try to do whatever we can do to get closer to that. That's one thing. And the second question you asked is, how can you integrate all these things into a single decision you are making, right? So, sorry? Same patient's data. If it is available, well and good. If not, we are not going to be able to do that, right? So it's all, that's why I said it depends on the availability. Otherwise, we might have to simulate, which is not straightforward. So the closer match from the same population group, if we can get that, then we can use those features together. And it again depends on the application you are going to use. If we are going to look at some sign, which depends on hypertension, hypertension affects these modalities very much. Brain gets affected, retina and heart obviously gets affected as well. So you can combine the quantitative measures from all these and put up a single quantitative measure or a single scale to say that this patient is going through a worse condition. Like we should probably look at the health condition of that patient. Right, we are long way away from that. So a long way to go. Some labs are doing that, but we need to have data for that. It's a very data-driven, stream of research.
Okay, I'm also working on the same area, and the thing is, I'm having two questions.
Yeah.
First one is, you said about adding noises. There are 4 types you were making, and you are adding noises. So how well it will be? Are you using the same method for all the 3 modularities, or are you performing different type for data generation? That is my first question. Second question is, like in federated learning, why can't we find methods to generate data instead of prediction in separate places, separate clinics, so that we will get a large amount of data creation without any prior knowledge of how it will be, what impacts it will give?
Yeah, so it's kind of a combination of both. We do generate data. So one thing, that this is a very preliminary work we just started using multiple scales. So if you notice, we haven't included any dark lesions in there, like hemorrhagic lesions or blood leakage or anything. So we have started working with bright lesions, but our next step is to see if there is any way of automatically biasing the model towards any particular scale, depending on what we are seeing in that population. And from there, the natural extension would be including dark data as well. So the simulation of unseen data is not as easy as you think, because the variability, can you exhaustively model the variability in the data? So that is going to be a question always. Right, we can only generate data based on the instances we have seen so far, because the model has seen it. So what if we want more variability to work on unseen data sets? Right, so that's why we are actually going for some real data from different centers. So the belief is that the more and more centers are being added, the variability will increase. So we will essentially improve the robustness of the model itself. And this applies for the federated learning framework also.
Hello, ma'am. Sorry. I just wanted to know how does position gets encoded in through the encoder. I don't generally understand. That was the question.
Okay, so that's integrated in the architecture of the transformer generally. So vision transformer, because it takes images. So what happens is it actually wants, the aim is to take context where what is happening and where it is happening. So we want to break it down into small patches and want to take the location of the patches. It's just numbering, a simple numbering of patches, and encode these locations as an additional input, basically just appending or concatenating this with the linearized vector of features and sending it to the encoder. So the encoder learns the position, basically an ordering of information, right? In the cryptography, you just have the crypt bit and then the actual information bit, right? So just like that, appending it and sending it to the encoder. And it is basically the whole feature along with the position is being encoded in the encoder, the MLP encoder.
Now, since we seem to be running out of time, okay, the last question.
How to decide the K values in the clustering? Because the progression, it will go for the initial image, which is the training data. And if the image different in the validation data, how do you decide the K values in that?
Are you asking for the specific application I showed in clustering?
Yes.
Yeah, so that depends very much on the data. For CT, we have quite a poor contrast. So we know that there is this white matter of the brain, and then we have this lesion, actual lesion. So they have different contrast. Their contrast is very good when compared to the skull and, sorry, it's moderate compared to the skull and the tissue. So we wanted to over segment it so that we want the unit to learn, the actual model to learn the refined structures rather than giving an over segmented clustered output to the model itself. So we always set the high number of clusters for it. So essentially, generally, how would you set up the cluster? So there are methods like DBScan hierarchical clustering where you can actually set up the number of clusters, right? So this is a simpler application. So we didn't want to go through all these because we know what the data would look like. So we just wanted to set one cluster for lesion and 2 more clusters for the background. So we went with 5 for this.
Let me thank Vaanathi again for a great talk.